Welcome. Today we're jumping into a really fundamental topic in radiation oncology.
Yeah, the principles behind combining chemotherapy and radiation therapy.
Exactly. And we'll get familiar with the major drug classes you'll definitely encounter when treatments are combined.
This is really essential knowledge, not just for your boards, but, for understanding why we make certain treatment decisions every day.
Right.
So we're going to try and boil down the key concepts, look at how these powerful treatments interact, and introduce the main chemo drugs used with radiation. We'll focus on their mechanisms and why they matter to us.
Think of this as getting straight to the core insights you need, hopefully in a memorable way. Okay, so let's start with the most basic question. Why? Why do we combine these two powerful approaches in the first place? What's the main idea?
Well, the most fundamental reason, kind of the bedrock principle, is something called spatial cooperation.
Okay, spatial cooperation. Let's unpack that a bit. What does that mean, practically speaking?
Think about it like this. Radiation therapy, it's our go-to tool for really precise local control, right?
Mm-hmm.
We target a specific tumor, maybe some nearby lymph nodes, and we hit it hard with radiation right there. It's incredibly effective at wiping out disease within that target area.
Yeah, fantastic local control. But the problem is cancer isn't always just, in one spot.
Exactly right.
Yeah.
It can be a systemic issue. You might have microscopic bits of cancer, tiny clusters, even single cells scattered way outside our radiation field, maybe in distant nodes we aren't treating, or even in other organs.
The seeds for Mets later on.
Precisely. Those potential distant metastases, radiation alone just can't reach them if they're outside the beam.
And that's where chemotherapy makes its entrance.
Yes. Chemo travels systemically through the bloodstream, reaching potentially anywhere in the body. It hits the primary tumor, sure, but critically, it can also find those micrometastases that radiation misses.
So, spatial cooperation. It's using radiation's precision for the local job and chemo's systemic reach to handle disease elsewhere.
That's the core idea. Radiation for excellent local and regional control, chemo for tackling systemic or micrometastatic disease, and importantly, chemo can also add to the cell kill within the radiation field itself.
Got it. Now, this combination, it's not always given at the exact same time, right? Sometimes chemo comes first.
Correct. We might give chemo before radiation. That's neoadjuvant therapy. The idea there might be to shrink a large tumor to make radiation easier or more effective, or to hit those micrometastases early.
Or it can come after radiation, adjuvant therapy.
Yeah, adjuvant therapy aims to clean up any microscopic disease that might be left behind after the main local treatment.
And then very often, we give them together, concurrently.
Right, and giving them concurrently brings up a really critical point.
Mm-hmm.
How do their effects actually interact when they're given at the same time?
Because it's not always just simple addition, is it?
Not at all. When you combine treatments, their effects can interact in basically one of three ways. Understanding these is really key.
First up?
The simplest interaction is additivity.
Okay, additivity. Sounds like they just add up.
Pretty much.
Yeah.
The combined effect is just the sum of what each would do on its own. Effective A plus B equals effective A plus effective B, simple sum.
Straightforward. What's next?
Next is synergism, or sometimes called potentiation. This is often what we're hoping for with concurrent therapy.
Ah, okay. This is where it gets really interesting. More than the sum of the parts.
Exactly. Synergy means the combined effect is greater than the sum of their individual effects. Effective A plus B is more than effective A plus effective B. You get a bigger bang for your buck when they work together.
Like maybe the drug stops the cancer cell from fixing the radiation damage? Something like that?
That's a perfect example.
Yeah.
If a drug inhibits DNA repair, that's DNA repair, the radiation damage becomes much more lethal. That enhanced sensitivity, that's synergy.
Okay. And the third interaction, the one we want to avoid.
That's antagonism.
So they actually work against each other.
Yes. The combined effect is less than the sum of their individual effects, maybe even less effective than one agent used alone. Effective A plus B is less than effective A plus effective B. One treatment is actively interfering with the other.
Like if a drug stops cells in a part of the cell cycle where they're naturally more resistant to radiation.
That's a classic mechanism for antagonism. If a drug arrests cells in, say, a radioresistant phase like the S phase, it could inadvertently protect them from the radiation. Not what you want.
Okay, so we've got additivity, sum, synergism, greater than sum, the goal, and antagonism, less than some avoid.
Exactly. And we're usually aiming for synergy to boost that tumor control, ideally without a proportional jump in normal tissue toxicity.
Yeah.
Though often toxicity does increase too.
Right, the therapeutic ratio. Okay, to help remember these, how about a quick mnemonic?
SAA?
SAA.
Yeah. Sum for additivity, aim. Synergism is the aim. And avoid, antagonism is what to avoid. SAA. SAA. I like it. Simple. Sum, aim, avoid. Okay, so now we know why we combine spatial cooperation and how they can interact, SAA. Let's get into the who, the major classes of chemotherapy drugs we use with radiation.
Right, let's meet the players. Starting with alkylating agents.
Okay, alkylating agents. These are highly reactive chemicals. They work by directly adding alkyl groups onto the DNA molecule. That's DNA again.
Alkyl groups. What does that do to the DNA?
It causes damage, things like strand breaks, but also, importantly, it forms crosslinks. These can be within a single strand intrastrand or between the two strands interstrand crosslinks. Think of it like chemically handcuffing the DNA. It physically blocks the enzymes trying to replicate or transcribe the DNA.
So it just gums up the works directly on the DNA. Are they specific to any part of the cell cycle?
Generally, no. They're considered cell cycle phase non-specific. They can damage cells pretty much whenever.
Examples we see a lot.
Well, cyclophosphamide is a big one. You see it in lymphomas, leukemias, breast cancer. It's actually a prodrug, needs activation in the liver. And temozolomide, that's the standard of care, really, for glioblastoma, given concurrently with radiation. It's an oral pill.
And don't forget the nitrosurias, like carmastine, BCNU, and lomastine, CCNU.
Good point. Yes, the nitrosurias. They're known for being able to cross the blood-brain barrier, which makes them useful for brain tumors.
Okay, next class, antimetabolites.
Antimetabolites. These are quite clever, really. They look like the normal building blocks, the metabolites that cells use to synthesize DNA and RNA. That's RNA.
They're imposters.
Exactly. They act like decoys. They either interfere with the enzymes needed to build nucleic acids, or they actually get incorporated into the growing DNA or RNA strand, messing it up from the inside.
So they sabotage the construction process. That sounds like it would hit hardest when the cell is actually building DNA.
Precisely. They are primarily S-phase specific. That's when DNA synthesis is in high gear.
And key examples we use with radiation.
Methotrexate is a classic. It's a folic acid antagonist, blocks an enzyme called dihydrofolate reductase, which is vital for making DNA precursors. Used in head and neck cancers, other things too.
And the big one, 5-FU.
Yes, 5-fluorosul-5-FU. It's a pyrimidine analog, inhibits thymidylate synthase, another critical enzyme for DNA building blocks. Hugely important in GI cancers, that's GI cancers also, breast, head, and neck, very commonly given concurrently with radiation. And there's an oral prodrug version too, capecitabine.
Gemcitabine fits here too, doesn't it?
Yes, gemcitabine, another nucleoside analog. It gets incorporated into DNA, known to be a potent radiosensitizer, used in pancreatic, lung, ovarian cancers.
Okay, moving along to platinum analogs.
The platinums, so cisplatin and carboplatin. Now, they're similar in some ways to alkylating agents because they damage DNA, but the mechanism is distinct. They form these covalent adducts and crosslinks, mostly binding to guanine bases in the DNA. This distorts the helix structure, inhibiting replication and transcription.
Similar result, messed up DNA, but different binding.
Yeah.
Cell cycle?
Also, generally considered nonspecific, though some data suggests S-phase might be a bit more sensitive. But cisplatin, it's just a cornerstone agent for concurrent chemoradiation.
Absolutely. You see cisplatin everywhere. Head, neck, cervical, lung, bladder, ovarian. Its ability to cross-link DNA really complements the double-strand breaks from radiation. Makes repair tough for the cancer cell.
Right.
But you have to be mindful of its toxicities. Kidney damage, nephrotoxicity. Hearing loss, ototoxicity. And a nerve damage, neurotoxicity. Those are the big ones.
Exactly. And carboplatin? Similar mechanism, but a different side effect profile.
Less of the kidney, hearing, nerve issues with carbo.
Generally, yes. Carboplatin's main dose-limiting toxicity is myelosuppression, hitting the bone marrow and lowering blood counts. So it's often an alternative when cisplatin's other toxicities are too risky for a patient.
Makes sense. Okay, what about topoisomerase inhibitors?
Right, topoisomerase inhibitors. These drugs target enzymes called, well, topoisomerases. These enzymes are crucial. DNA is this incredibly long molecule all tangled up, and topoisomerases manage its shape, its topology, especially during replication and transcription. They basically cut the DNA strands to relieve tension or untangle them and then stick them back together.
And the drugs interfere with that cutting and pasting?
They do. Topoisomerase I inhibitors stabilize the complex after the enzyme has cut a single strand, but before it religates it. If a replication fork runs into this nick, it becomes a double-strand break. Topoisomerase II inhibitors trap the enzyme after it has cut both strands of the DNA, preventing religation and leaving a persistent double-strand break.
So they cause strand breaks by messing with the DNA maintenance crew, right? Cell cycle.
Many of them are most active in S phase or G2 phase, when the cell is actively replicating DNA or getting ready to divide, which requires a lot of topoisomerase activity. For topo-1 inhibitors, think irinotecan and topotecan. For topo-2 inhibitors, etoposide, also called VP16, VP16 is a major one, and doxorubicin, which we'll meet again, also inhibits topoisomerase II.
Okay. How about microtubule targeting agents?
Microtubules. These drugs go after the microtubules, which are part of the cell's internal scaffolding, but critically, they form the mitotic spindle, the structure that pulls chromosomes apart during mitosis, during cell division.
Ah, so like the vinca alkaloids and the taxans?
Exactly. Those two groups. Vinca alkaloids like vincristine and vinblastine bind to the tubulin proteins themselves and prevent them from assembling into microtubules. No assembly, no spindle. This causes cells to arrest in M phase.
And taxans?
Taxans like paclitaxel and docetaxel do the opposite. They bind to microtubules that have already formed and stabilize them, preventing them from disassembling. The spindle needs to be dynamic to grow and shrink, so preventing disassembly also messes it up and leads to M phase arrest.
So both groups stop cells in M phase mitosis.
Primarily, yes. They target that process directly. Paclitaxel in particular is often used as a radiosensitizer, especially in settings like head and neck or lung cancer.
Got it. And the last big group, anti-tumor antibiotics.
Yeah, this is a bit more of a diverse category. Most of them interact directly with DNA in some way.
Okay.
The anthracyclines like doxorubicin are a major subgroup. They slip between the DNA base pairs. It's called intercalation, which messes up the helix. Doxorubicin also inhibits topoisomerase II, like we mentioned, and generates damaging free radicals.
What else is in this group?
Bleomycin is another one. It causes DNA strand breaks, mostly through generating free radicals. And then there's mitomycin C. It's an alkylating agent, technically, that cross-links DNA. Yeah. But it's special because it's bioreductive. It gets activated preferentially in hypoxic, low-oxygen environments.
Ah, that hypoxic activity is really interesting for us in radiation oncology. Cell cycle specificity for these antibiotics.
Mostly considered non-specific, although bleomycin does tend to make cells pile up in the G2 phase.
And clinical pearls or warnings for these when used with radiation.
Doxorubicin, used very widely, but you always worry about cardiotoxicity, heart damage, and that risk is definitely increased if you're radiating the chest area concurrently. It can be a radiosensitizer, though.
And bleomycin?
Bleomycin, used in lymphomas, some squamous cell cancers. The big warning sign is pulmonary toxicity, fibrosis, and radiation to the chest dramatically increases that risk. Very important interaction to know.
And mitomycin C.
Mitomycin C, you see it often in GI cancers like anal cancer, frequently combined with 5-FU and radiation. That activity in hypoxic cells makes it a rational choice there, as hypoxia is a known cause of radioresistance.
Wow. Okay. That's a great tour of the major drug classes. It really helps to understand how they work. Maybe we can solidify this with a quick case.
Sure.
Let's take a common scenario. A patient with locally advanced head and neck cancer. Standard approach often involves radiation to the primary site and neck nodes, plus concurrent chemotherapy.
Right. And as we said, a very frequent chemo agent used there is cisplatin.
Okay. So, applying what we just discussed, why cisplatin? What's the thinking behind combining it with radiation in this setting? What kind of interaction are we hoping for?
Well, we know cisplatin is a platinum analog, and its main job is forming those DNA crosslinks.
Yeah.
Right.
The intra and interstrand crosslinks.
Exactly. And radiation, its primary lethal damage comes from causing DNA damage, especially double-strand breaks. So when you give cisplatin at the same time as radiation...
Cisplatin is putting its own damage, the crosslinks, onto the DNA.
Yes. And those cisplatin-induced lesions, those crosslinks, they make it harder for the cell's repair machinery to fix the breaks caused by the radiation. The damage becomes more complex, harder to deal with.
Ah, so it's hindering the DNA repair process. That's the key to the synergy.
That's a major part of it, yes. You get the direct damage from both, plus the chemo interferes with the repair of the radiation damage. So the combined hit is much more effective at killing the cancer cell than either agent alone would be. We're aiming for that synergistic effect to overcome resistance and improve cure rates.
That makes perfect sense. Seeing it in a clinical context really highlights why knowing the mechanism helps understand the strategy.
Absolutely. And knowing these classes and interactions is just so critical in practice for multiple reasons.
Like just choosing the right combo in the first place, picking drugs known to be radiosensitizers, or ones that target specific things like mitomycin C for hypoxia.
Definitely. And crucially, for managing toxicity, combining treatments means you have to anticipate combined or even synergistic toxicities. We mentioned bleomycin and lung fibrosis with chest-RT or doxorubicin and cardiotoxicity. You have to know those potential amplified risks.
It also helps decide on the sequencing neoadjuvant, concurrent, adjuvant. That depends on the drug, the goal, the tumor.
And exploiting cell cycle effects. If a drug pushes cells into a more radiosensitive phase like G2M, giving it concurrently could, in theory, maximize the kill when the radiation hits.
Okay, great discussion. Let's try to distill some clinical pearls from this. High-yield points for boards and practice.
All right. Pearl number 1. Always remember spatial cooperation. Local radiation therapy plus systemic chemo. That's the fundamental reason for combining them hitting disease locally and systemically.
Pearl number 2, know the interaction types. Additivity, some, synergism, greater than some, the goal, and antagonism, less than some, avoid. Our SAA mnemonic helps here. Some, aim, avoid.
Pearl number 3. Get comfortable with the major drug classes, their basic mechanisms, and cell cycle specificity. Alkylating agents and platinums damage DNA nonspecifically. Antimetabolites hit DNA or RNA synthesis, mostly S phase. Microtubule agents target mitosis, M phase specific.
Right, and no key examples like cisplatin, 5-FU, paclitaxel.
Exactly.
All right, feeling sharp. How about a quick board blitz?
Let's do it. Hit me.
Question 1. A patient gets concurrent chemoradiotherapy for head and neck cancer with cisplatin. What's the main mechanism for cisplatin's cytotoxic and radiosensitizing effect here? Is it A, inhibition of thymidylate synthase, B, cross-linking DNA strands, C, stabilizing microtubules for M-phase arrest, or D, scavenging free radicals?
Okay, cisplatin, platinum analog. Its job is DNA cross-linking. So that's B, cross-linking DNA strands.
Correct. Question 2. Using radiation for local control and chemo for potential distant micromets is best described as A, synergism, B, additivity, C, temporal cooperation, or D, spatial cooperation.
That's our foundational principle. Different locations, different modalities. That's D, spatial cooperation.
Perfect. Question 3. Which chemo class primarily interferes with DNA synthesis and is typically S-phase specific? A, alkylating agents, B, taxanes, C, antimetabolites, or D, anthracyclines?
Interfering with DNA synthesis, S phase. That sounds like the decoys, that's C. Antimetabolites, like 5-FU.
You got it. Last one, question 4. A drug results in a combined cell kill with radiation that's greater than the sum of the kill from each alone. What interaction type is that? A, additive, B, antagonistic, C, competitive, or D, synergistic?
Greater than the sum of the parts. That's the definition of D, synergistic.
Excellent. Okay, let's quickly wrap up what we covered.
We started with the why spatial cooperation as the key reason for combining chemo and radiation, tackling local and systemic disease.
Then we looked at how they interact: additivity, some, synergism, aim for this, and antagonism, avoid this. Remember SAA.
And we went through the major who the key chemo drug classes use with radiation, alkylating agents, antimetabolites, platinum analogs, topoisomerase inhibitors, microtubule agents, and anti-tumor antibiotics. We touched on their mechanisms, cell cycle points, and gave key examples like cyclophosphamide, 5-FU, cisplatin, etoposide, paclitaxel, and doxorubicin.
Understanding all this is just fundamental. It underpins so much of modern combined modality cancer treatment.
Definitely. We talked a lot about the general mechanisms of these drugs and how they tend to interact with radiation.
Right, like the cisplatin DNA cross-linking example, enhancing RT damage.
Exactly. But it makes you think. Looking ahead, given how different every patient's tumor is, genetically, biologically, the microenvironment, how do we get better at predicting which specific combination will give the most synergy with the least extra toxicity for that individual patient? What are the specific markers or pathways within a tumor that really dictate whether cisplatin or gemcitabine or something else will be the best synergistic partner for radiation in their specific cancer? That feels like the next big challenge.
That's a great thought to end on. Moving towards truly personalized combined therapy. Well, thanks for joining us today. Remember, you can complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next session.
Thanks for tuning in.